Thank you very much, Dr. Abbas. Very nicely presented, mashallah. सर डॉक्टर बुशरा और डॉक्टर अवैस ने सब कुछ तो पढ़ा दिया जी. अभी तो बस एक पेशेंट रह गया है कि जिसको अब CPR चाहिए बस. We will discuss a little about it. So we are doing this day-to-day practice, CPR, but we are discussing. It will be brief, I hope, inshallah. So we will have a good amount of time to take the tea. So we know that in pediatrics, most of the time we have the respiratory compromise that progresses and leads to cardiac arrest. In comparison to the adults, where the acute cardiac arrest is the mainly common presentation. So again, the emphasis is to rapidly detect and promptly intervene so that the patient should not go in cardiac arrest where it will be difficult to bring it back to the baseline. So shock, we know already, actually it is discussed, it is just the mismatch between demand and supply. So it is impaired tissue oxygenation and perfusion. We know already actually discussed all these things. The shock, it could be just the decrease in the oxygen delivery. Either the delivery is less or the supply is more. So it is a demand and supply mismatch. So we just need to either increase our supply or at the same time we need to decrease our demand. So oxygen delivery, we all know that it is determined by the blood pressure, cardiac output, and oxygen content. We know all this. So the oxygen delivery determinants are so for the effective cardiac output, we know that that was the formula discussed by Dr. Bushra. That it is the stroke volume multiplied by the heart rate that determines our cardiac output. So the stroke volume will be determined by our preload, contractility, and afterload. So fluids are for the preload. Vasoactive agents are if our contractility is compromised, and of course our oxygen carrying is done by the hemoglobin. So a set level of hemoglobin is also important. So we can do that with the supplemental oxygen wherever is indicated. So what are the clinical determinants for that? So when we see the patient clinically, we do have some clinical assessment, and we have that, like most commonly organs that are affected by the poor oxygenation. It is our mentation, that if the oxygen is not supplied, mentation will be altered. So these are the two most common organs that are affected. The first, because both of these use a lot of oxygen, and it's the vital organs. So if the oxygen is compromised, the patient may be irritable and drowsy, and then may be unconscious. And oliguria, we know that whenever the patient goes in shock and the supply is inadequate for any reason, the urine output is affected, the first thing. Metabolic acidosis, of course, we know that it is the anaerobic whenever it's compromised. Aerobic metabolism is whenever is compromised. The end will be the anaerobic that will ultimately lead to lactic acidosis. And with the worsening renal perfusion, we will end with worsening renal functions. And of course, the whole body is getting compromised. So the liver is also affected by increasing transaminases. So compensatory mechanisms, all the body, the nature has given us a lot of compensatory mechanisms. So if there is decreased delivery to the oxygen to the body, so it is compensated by increasing the heart rate. That we know that in pediatric age groups, it is mainly the heart rate that is helpful to increase the cardiac output and blood pressure in comparison to adults where the stroke volume is the main determinant. And vasoconstriction, so the body actually shifts the circulation to the vital organs. So that is why in shock states, we see that the peripheries are cold. So these are actually the physiological compensations. Okay, next. So we know all this. Whenever we come across a patient in shock, they tend to be tachycardic, tachypneic. Actually, these are all the compensatory mechanisms. The body knows that the oxygenation is not inadequate. So these are the compensatory mechanisms to increase the cardiac output and oxygen supply. So, but these are the actually the alert signs. So the physician should be alert enough to not let the patient to go in decompensate stage. So these are the signs during the compensatory phase. Hypotension, as mentioned earlier during previous two presentations, is the late sign. So that is not the time to intervene. It's much more earlier. So especially in younger children, we need to see the liver. If the liver is increasing in size or it is descending, then we need to plan accordingly. Okay. So the children are not the young adults. They have a good amount of differences. Infants and children have higher baseline heart rates. We already know that. Infants have fixed stroke volume. It means that their compensation is through increasing the heart rate rather than the stroke volume. Bradycardia, this is very important. In adults, heart rate is already low. So that is, but in pediatric age group, if the heart rate is coming down, that is a pre-arrest phenomenon. Children can markedly increase the systemic vascular resistance. That is why I already mentioned that they have cold peripheries. So the lot of the blood that is going to the non-vital organs is shifted to the vital organs in emergency situations. Hypotension or bradycardia are pre-terminal events. So the pre-cardiac, pre-arrest situation if the patient is in bradycardia or is in hypotensive state. So we all are familiar with these types of shock. Hypovolemic, that is most commonly seen in pediatric age group. Cardiogenic shock is also not uncommon. Distributive, it's partially hypovolemic maybe. Obstructive shock is also very common. And in some circumstances, we come across with the anemic shock as well. This is very important to know the shocks are maybe compensated or maybe hypotensive. So this is the time to intervene rather than with this one. So golden hour for shock management, it's not something new. We know all this. Time management is very important. If the things are done rightly in late after 1 hour, they will be much less fruitful rather than if these are done adequately in a timely fashion. So we know that as soon as we come across a patient who is found in shock, that is recognized by the clinical signs and symptoms. So we recognize the shock, the patient is in altered mental status, is irritable, and clinically the perfusion is not good. So what is the first thing we do? We put on oxygen and we get the access. Already most of the people would have done the PALS. So this is actually the PALS algorithm. So as per PALS, we put on nasal high flow oxygen. That is generally by non-rebreathing mask. And we try to get IV access. If there are 2 attempts and we are unable to get that, IO should be placed in. So in the meanwhile, we need to assess the patient is in failure or not. So if the patient is in failure, then we need to give, still we need to give the volume, but of course the volume and the frequency will be less. So generally we give 20 mL per kg of isotonic boluses, maybe in the form of normal saline or maybe Ringer's lactate. We can give 2-3 boluses. Actually, know that there are some changes. So the people say it's better to give like a bit restricted, maybe 40 mL. But again, it depends on the clinical condition of the patient. But in the meanwhile, while giving the boluses, we need to check if the patient is going in failure or not by checking the liver is descending or there are any crepitations. So we are doing all these side by side. It's not like 1, 2, 3. We all are doing side by side. We will check the blood glucose. If it's hypoglycemia needs to be fixed. Hypocalcemia, especially in younger babies, is very important. That is actually like an inotropic. So, of course, if the patient is septic, so we need to give antibiotics after taking the cultures as one of the first things. So when we label the fluid refractory shock, if the 2 or 3 boluses have been administered, still the patient clinically is not improving, vital signs are not getting, heart rate is not coming down, respiratory rate is not coming down, sets are not improving, perfusion is not optimizing his, irritability is not improving, then actually these are the signs we always detect, intervene, intervene and reassess. It's an ongoing process throughout the presentation and through the course. So if the patient is not improving with the shock, his signs of shock are not getting better, then we start the inotropic support. Initially, people used to say the dopamine, but the preferable drug is epinephrine. Small doses can be given through the peripheral line. Later on, a central line can be used. So these are the drugs in hypotensive patients. For getting the central line, we need to give some sedation. So here we use the drugs which don't cause hypotension. Ketamine is one of the best choices. Airway reflexes as well. So the other drugs that can be used is the dopamine. Norepinephrine can also be used in cases of warm shocks. And next, please. So first is giving lots of volumes and revalue the patient. Patient is not responding to the volumes, then we start inotropes. Okay, now we are almost at 1 hour. The patient is not improving with giving the volume, starting inotropes, and now there are some patients who are catecholamine resistant, so we can try the hydrocortisone here. So there are certain numbers which can be utilized if we have central line. So mixed venous that was discussed by Dr. Bushra. That we get from the central, actually the exact side to get the mixed venous is our PAs, the pulmonary artery. But of course, that is quite invasive. And that's very, when we get the IJ or subclavian, it's more or less similar to the mixed venous. So it is almost 2/3 of our systemic one, 1/3 is utilized in routine. So our target is to match the demand and supply. So if the supply was less in that particular patient, so we increase the supply and we need to target our mixed venous, that is 70% of the arterial one. That is our, we can see on our monitor. So there are certain situations if the BP is normal, the patient is in cold shock. So epinephrine may be the preferable choice. If the BP is low and the cold shock, the hemoglobin may need to be optimized. If there is low pressure and warm shock, the patient is a candidate to start the vasopressors, and generally norepinephrine. In certain situations, vasopressin can also be used. So milrinone can be used in the situations where the pressures are okay, but our peripheries are cold. So these are the situations where the milrinone can be used. So we discussed that actually. Persistent catecholamine resistant shock, refractory shock. Actually, these are not available with us, but in these situations, it is better to consider the mechanical ventilation. Okay. So during resuscitation, we are monitoring either our resuscitation is helping to the patient or not. So it's continuous ECG monitoring we are doing every day in our ICUs. Blood pressure in 3 to 5 minutes. So it needs to be continuously observed. Pulse pressure is important. If there is peripheral vasodilatation, like in patients with shock, the pulse pressure will be increased. In all distributive shocks, either it is a neurogenic shock, hypothermia, hyperthermia, both are not good for the patient. Hypothermia will cause the problems like coagulopathy. Hyperthermia will increase our metabolic rate. So already we are deficient in oxygen and nutrients. So urine output is very important and an objective surrogate for the cardiac output. As point of care glucose on admission needs to be done hourly and then can be decreased later on. Okay. So when we are at this stage, we have given the boluses, we have started the inotropes. In refractory cases, we have started the steroids. Still, the patient is not getting better. So this is a very important thing we need to always consider. We know that when the patient's in respiratory shock, we immediately intubate the patients. But shock is a very important indication to be supported by the respiratory support or mechanical ventilation. Because when the patients are sick, so they are 30 to 40% of the energy is being used for the respiratory system. So if we take over, so we are conserving 30 to 40% of the oxygen. So it can be used by the face mask in relatively stable patients, non-repeating. We are getting 100%, but we are not getting any PEEP. So it's not a positive pressure. High flow is actually much more. So we can go up to 30, 40 liters per minute. CPAP, BiPAP for special circumstances. But of course, it needs close observation. Intubated patients are much more safer than the BiPAP as far as we're talking about the observation. These are the patients who need very close observation, whether they need more support or not. Generally, regular low flow nasal oxygen cannulas are not adequate in these circumstances. Okay. So, resuscitative fluids. This is only for hypoglycemia. We give dextrose 10%, or if available 25%, that can be diluted to 1:1 and that can be given. Of course, with the peripheral line, giving 25% will be much more hyperosmolar. Isotonic 10 to 20 mL per kg, but the only concern is hyperfluoremia, hyperfluoremic acidosis that can happen if we give large and large abnormal saline. Ringers is better in that regard. It does not cause, but there is, although it's a small amount of potassium in ringers, but still it can cause if we need to give large ringers. Colloids 5%. It's a bit expensive, works as good as the saline and the ringers. If the patient is anemic, hemoglobin is low, then PEPT RBCs may be helpful. And if it's not available, the FFPs are not the replacement actually. We want to increase our oxygen delivery. That can only be done by giving PEPT RBCs. So normal saline with additives, the maintenance, we all know that. Okay. Next, please. So it's very important. We are we are managing a patient who is in shock. So many of the medications that are used for intubation that can compromise our hemodynamic status. So it's very important to select the medications what we need to give for intubation. There are certain pre-medications like atropine that will decrease the excessive secretions. That is a side effect of ketamine. That is the drug of choice actually for hemodynamically compromised patients. Ketamine, some people don't use for neonates, so fentanyl is the alternative. With the ketamine, the only thing we need to actually know that sometimes it causes a lot of secretions. It can initiate the cough and vomiting. So we should be ready to handle that if we come across. Atropine is very helpful and to pre-medicate before ketamine. With the fentanyl, sometimes the kids, they have very tight chest. So it is one of the side effect with the fentanyl, especially in small kids, the neonates, the chest rigidity. So the only thing that helps at that time is giving the paralysis immediately. It's no way to ventilate these children if these there is the chest is the chest is not expanding at all if they get this side effect. So for the neuromuscular blocking only, it should be given if we are sure that we are able to embubag the patient. If we are unable to embubag the patient, neuromuscular blocking agent should not be used. Fentanyl and low dose midazolam for comfort safety during transport, but we need to be very careful when the patient needs the support. If the patient is getting extra effect, sometimes small dosages and the effect is much more than what we consider. Avoid large doses of morphine and midazolam because both of these will cause significant hemodynamic compromise. And the morphine has histamine release effect, so vasodilatation, and the causing hypotension, and midazolam has the Bose effect. It has direct cardiac depressing effect and as well as the peripheral vasodilatation. Of course, the phenobar and propofol, these the barbiturates are not the right choice in these circumstances. And the propofol again, because it has significant hypotensive effect. So vasoactive agents. So for the peripheral line, we can use the small dosages of epinephrine. Generally, it is safe. Dopamine is the alternative if epinephrine is not available. It can be used through the intraosseous lines as well. So if the shock is persistent, warm shock, norepinephrine, and if the patient is not improving with small dosages, we need the central line. If we need to increase the dose, for the cold shock, epinephrine is a better choice. Okay. Next. So it's a goal-directed therapy. So the most common signs and we come across in a shock patient tend to be tachycardic, ultimately they will be hypotensive. So heart rate, and if the patient is awake, the respiratory rate. These are very important. So we should know the normal numbers so that we should know that when we need to intervene further if these numbers get abnormal. So the mentation is very important because it reflects the oxygenation to the brain. Capillary refill, the normal is less than 2 seconds. And the strong distal. So generally our central pulses are reasonably good in any type of shock, but the peripheral pulses are important. Okay. And serial laboratory tests, of course, the glucose, especially in young babies. CBC, cultures, and chemistries, and these always we take during resuscitation. If the patient is not improving and requiring escalating dose of inotropes, we need the central line. We can check our metabolic status by getting lactate, as discussed earlier. It's a very important marker to check whether our patient is coming out of shock or not. And the values are repeated to check our response. Okay. So now there are a few cases. A previously healthy 2-month-old boy who had gastroenteritis and is lethargic. His heart rate is quite high, hypotensive, tachypneic, temperature is up at the low side, oxygen sets are still within limits. is mortal, spontaneous depressed, cold extremities, steady pulses, chest is normal. Okay. Okay. So what is the impression? What sort of shock is he having? Hypovolemic shock, mashallah. Okay, next. So does this patient have shock? Okay. So this is the most common shock we know all, and dealing every day in our emergency and ICU sections. So the first thing is to get the IV access or the intraosseous. Rapid boluses, as discussed earlier, generally normal saline and Ringer's lactate are enough. The additional fluids, if the patient is losing more and more, we need to give more. Hypoglycemia, especially in this age group, is very common and needs to be fixed. And electrolytes, hypocalcemia, also very important in younger babies. So we need to give the volumes, reassess, giving the volume. So detection, intervention, and then reassessment. It is an ongoing process. Okay. Okay. Next. So what is the initial management? It's actually discussed already. Go ahead. So 16 years old adolescent is malaise and then collapses. Looks ill, tachycardic, 16 years is quite hypotensive, tachypneic, SATs are still maintained, normothermic, motor skin, steady pulses, and cold lower extremities. Crackles and hepatomegaly is noted on examination. Blood glucose is normal. It is pH is 7.16 with PCO2 20. Ionized calcium is normal. So what type of shock this child is having? Sorry? Cardiac shock. So cardiogenic shock is. So generally when we say that any patient who is having crackles and hepatomegaly, the cardiac functions are down. Okay. So what is the initial management plan? Okay. So cardiogenic shock, like in other patients, ABC is of course the priority. We give fluids, but not as much as in hypovolemic shocks. So we give small allocates and then reassess. Vasoactive infusions are started earlier than hypovolemic shocks, and of course the early cardiology referral is important. Because previously if this patient is fine, having arrhythmias, so if it is not fixed, it's not possible to get this patient back. So early cardiology referral is important in these patients. And any patient who is having arrhythmias, the first thing that we need to check is any electrolyte imbalance, because there are many patients who are pro-arrhythmic because of any congenital issues. They tend to have arrhythmias whenever there is any electrolyte imbalance. Okay, go ahead. So 7 days old infant, lethargic, poor feeding, respiratory distress, tachycardic, pressure is on lower side, tachypneic, SATs are okay, a bit febrile, motor skin, cold extremities, crackles, hepatomegaly. These blood glucose is fine, having some metabolic acidosis. So what ECG shows? S2. Very good. It could be sinus tachycardia. Okay. But so what is the initial management plan? Okay. How will we manage this? एसपीटी को क्या करेंगे जी? क्या करेंगे? डिफिब्रिलेट करेंगे? जल्दी नहीं कर दिया? Okay. Okay, go ahead. So cardiogenic shock due to SVT, it is a very common scenario. We always do in pairs courses. So ABC will stay same. If there is a time patient, we are not ready for the medications or the shock, we can use the wiggle maneuvers. But in these circumstances, this is not something preferred. So it is only if we have the time and we don't have the adenosine, then these patients can be wiggle maneuvers can be used. Adenosine, it's a rapid push. It has very short half-life. So we give like with the three-way cannula, we give the dose from one end and we push the saline 10 mils from the other end. Otherwise, it's not going to work. But in these circumstances, where the patient is already hemodynamically compromised, as our patient is, so this is the priority. So we need to always synchronize cardioversion to be used for these children. In the meanwhile, if there is a time, only then we use or we can apply these two steps. So verapamil should never be used for these patients among the medications for these. And of course, if the patient having any congenital or structural abnormalities, these tend to have these abnormal rhythms more frequently. So it needs to be excluded as early as possible. Okay. So Dr. Bushra actually discussed a little about these drug-dependent lesions. These are a bit less commonly seen if we compare with the other causes of shock, but these are very important because if these are not managed in time, then it's very hard to bring the patients back. So any patient with a cardiogenic shock, already we discussed, we give small boluses, not the like 20 mils, and in hypovolemic patients. So any like neonate, young baby who was doing okay, just gets blue without other real explanation. So we always need to exclude this condition. So prostine, unfortunately, it's not available in many centers, but that needs to be started immediately before doing any echoes. Because if the duct is closed, it's going to help, and we can borrow the time to find diagnosis and fix the problem. But if we go use the higher dose of prostine, it can cause apnea. So we should be ready to have the more stable airway for these patients. And of course, volume inotropes are required till we are able to know exactly what is the pathology is. Okay. So what this heart shows, it's a very big heart. Okay. 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 Next. So 16-year-old child has blunt injury, the neck and the upper back while playing. He's awake, anxious, unable to move. Heart rate is a bit lowish. BP is quite low. Respiratory rate is okay. Normothermic, SATs are okay. Pulse is readily palpable. Skin is quite flushed. Lungs are clear. Distended bladder felt on the abdominal examination. What is this? Sorry? Sorry? Okay, let's see that. Okay, go ahead. Go ahead. Okay, go ahead. Go ahead, please. So, what was the important thing in that? So the important thing is our the peripheries were quite warm and pulse pressure. So in these, ABC is always the priority. This patient who is like distributed shock, like in this patient, needs lots of volumes, ringers are isotonic, and these are the patients we need the peripheral vasodilators. Norepinephrine is readily available in most of the centers, but phenylephrine can also be used, or vasopressin. Generally, they do better with the fluids and the inotropes, but if they don't improve it, we need to use mechanical ventilation and bladder need to be decompressed. Okay. So 12 years old boy, unrestrained, front seat passenger, alert but dyspneic, ill appearing after sustaining blunt chest injury. For 12 years old, he is tachycardic, hypotensive, he is tachypnea. Other numbers are, so his SpO2 is 94% on 80% of oxygen. Skin is motile, pulses are weak, breath sounds are diminished on the right. He has tracheal deviation and abdomen is normal. So what's happening? So what additional study would be done? So, okay. So is it mandatory before intervention, or intervention can be done before? Yes. Okay, good. Okay, next. Go ahead. So needs to be needle decompression followed by the chest tube. Okay. But in the meanwhile, these are the patients. These actually are in shock. So we need to give some volumes in the meanwhile while doing the other maneuvers. Okay. So urgent decompression, giving volumes, and any patient who is in shock at the same time it's a painful procedure. That ketamine is a very good choice. Morphine, benzodiazepines may precipitate hypotension, and similarly the propofol. So if possible, needs to be avoided, but if it needs to be given, very, very small doses should be utilized. Okay. So 16 years old adolescent with knee pain, develops malaria, high fever. He is tachycardic, tachypneic, febrile, hypotensive, maintaining oxygenation on 100%, sick looking, flushed, bounding peripheries, lungs are clear, abdomen and heart otherwise looks normal. Okay, go ahead. Next. So what's the diagnosis? Okay, very good. Next, please. So how we manage these patients? Okay, like just our septic shock. Okay, go ahead. Go ahead. So warm shock, we all know these signs. So when we intervene these patients, so we need to check heart rate is coming down, appearance, the brisk refill is getting better, the pulses are getting less bounding, the pulse pressure is the less widening, and the pressures are improving or not. So the warm shock and the cold shock, having both are tachypneic, but it's pale, motile, and capillary refill is delayed. It's narrow pulse pressure in contrast to wide and warm shock, and ultimately will be hypotensive. Okay. So septic shock management, we discussed actually all this. So in catecholamine, refractory steroids can be given. Vasoactive agents, epinephrine can be used with the norepinephrine if indicated. As long as the pressures are on lower side, milrinone cannot be used. And the peripheries are shut down. So these are the circumstances where milrinone is very helpful. Okay. In case of shock, wherever we think that the patient needs lumbar puncture, it of course, needs to be done, but in controlled settings, not in this scenario at the start. So any patient who is hypovolemic, hypotensive, intubation is always risky. So it needs to be done by experts, and the medication, the choice of medications are very important, and the volume should be given as needed. So with time, as the condition changes, Vasoactive needs to be tailored accordingly. Okay. So we need to intervene before the patient goes in arrest. So timely resuscitation, medications with minimal hemodynamic effects like ketamine, or if needs to be intubated and it's not available, etomidate is another choice that has minimal hemodynamic effects, or small dose of fentanyl. Midas, morphine should be avoided as far as possible. Epinephrine is the preferred drug. Dopamine is an alternative. Central lines needs to be put in whenever the situation allows. Okay. Next. So the key is in shock or sick patients is the timely management. So in time recognition, the timely intervention will save the child. So initial resuscitation, 5 to 15 minutes. Fluid refractory should be labeled within first hour, and if it is labeled then catecholamines refractory shock, then we need to use the steroids. And if the patient is still not improving, may need more support and ICU settings. Okay. So the key message is timely recognition and intervention and reassessment, like in direct method. ABC, of course, is the priority. Fluids, early antibiotics, and correcting of the hypoglycemia and hypocalcemia, especially in younger kids, is very, very important. If the patient we are suspecting these are duct-dependent lesions, or the patient is cardiogenic shock, then the small elevates are important rather than the bigger ones. And prostaglandin needs to be used wherever is indicated. The intubation needs to be planned carefully in hemodynamically compromised patients. Okay. Thank you very much.